Today we'll take you through case-based discussion, very important topic that is acute coronary syndrome. So when you get a case of myocardial infarction, ACS in your exam, you can expect the questions in and around ECG manifestations, immediate therapeutic options, the timeline, so echo findings, so the complications of acute coronary syndrome, the reperfusion options what you have, the risk stratification of acute coronary syndrome, so long-term care, bit in and around hemodynamic monitoring, bit in and around vasoactive agent selection, bit in and around mechanical circulatory support devices. So all these things we'll try to discuss one by one as a case-based approach. So 54-year-old male present to emergency department with acute onset central chest pain for about 80 to 90 minutes. So comorbidities, if you see diabetes mellitus since 12 years, hypertension, dyslipidemia, active smoker, so about 30 pack years. So on presentation vitals, if you see heart rate is around 104 per minute. So BP is 98 by 62, respiratory rate 24 per minute. So on room is saturating around 92%, patient is afebrile. So he appears diaphoretic, anxious, pale. So what are the differential diagnosis of acute chest pain who presented to emergency department? So what are the immediate investigation you will order? So very important. So your viva starts like this. So an middle-aged male with multiple comorbidities. So chest pain. Okay, so tachycardia, blood pressure is borderline. So saturating around 92% on room air. What are your differential diagnosis? So life-threatening causes, okay, for the chest pain should be ruled out on priority. So in that first comes acute coronary syndrome. So ST segment elevated MI, so NSTEMI or unstable angina. So aortic dissection, massive pulmonary embolism, tension pneumothorax, acute pericarditis with a cardiac tamponade, esophageal rupture, what we call it as so Beroes syndrome. So severe acute pancreatitis, gastroesophageal reflux disease, or it may be simple musculoskeletal pain. But the like some sort of uh, exam pearl here is so patient is having a diaphoresis, autonomic symptoms, plus the risk factor with a multiple comorbidities. So acute coronary syndrome is the diagnosis until proven otherwise. So that you can give a message based on its clinical profile and clinical manifestation. So within 10 minutes, what investigations you are going to order? 12 lead ECG, so cardiac biomarkers including troponin I and troponin T. So any of these. So bedside blood glucose monitoring, capillary glucose. So oxygen saturation, get at least 2 IV access because BP is borderline. So ABG patient, if he is having a respiratory distress or shock is there, you want to understand the perfusion status. Chest X-ray, which helps in excluding aortic dissection and patient who is having a tension pneumothorax, that also we can get an idea by chest X-ray. So other baseline labs like so complete hemogram, so renal function test, liver function test, and coagulation profile. Okay, so these are some of the so first set of investigation we order in a patient who had chest pain with a background of multiple comorbidities who presented to emergency department. Okay, so this is the ECG we got. So just analyze this ECG. So suppose if you are suspecting him to be having so myocardial infarction, acute coronary syndrome. So describe the typical chest pain. So how it looks. Okay. So it's going to be retrosternal crushing or squeezing type of pain. So radiate to sometime left arm, jaw and back. So duration is persistent beyond 20 minutes. So not relieved by rest. It is associated usually with diaphoresis, nausea, dyspnea. Okay. So or sometimes with a palpitation and all. So this is how the typical chest pain of an MI manifest. But sometimes if a patient is advanced diabetic with a very uncontrolled HbA1c, he might not feel any chest pain. So that we call it as silent myocardial infarction. Okay. So how will you classify MI? Okay. So like all patients will have some sort of typical manifestation, or is there any different way how we can classify the MI? So comment on this ECG of the patient. Okay. So if you see the universal definition and different types of myocardial infarction, we have something called type 1 MI, which is a spontaneous MI due to atherosclerotic plaque rupture. So there is a pre-existing plaque. When it get ruptured or eroded or fissured, So that leads to complete occlusion of the lumen of the coronary artery with the intraluminal thrombus formation. Okay. So this is the most common MI. So it is indicated for antithrombotic and reperfusion strategy. So type 2 MI is secondary to oxygen supply demand mismatch. So without any acute plaque induced thrombus. Okay. Usually here, so myocardial supply is not matching the demand of the heart. So that mismatch leads to some sort of chest pain. So here we need to treat the underlying cause. So not a routine PCI. Okay. So type 3 MI, sudden unexpected cardiac death with presumed MI before the biomarkers are obtained. So here diagnosis is based on symptoms or ECG. So he had a cardiac arrest and died. So that is the type 3 MI. Type 4, we have ABC. So A is MI related to like percutaneous coronary intervention. Okay, that we call it as a procedure related MI. So MI due to stent thrombosis, so which is having a very high mortality, means stent was there, so then it get thrombosed. So MI due to in-stent restenosis. Okay, so that is the rarely like some sort of prescribed MI, that is 4C MI. So 5 MI is MI related to CABG, it is a surgical MI. So remember, very, very important, your Viva may not be very smooth. On ECS management, you can get all these questions. Okay. So other way of classifying based on the ECG, what we have like known since many years in our practice, one is STEMI. So ST elevation in contiguous leads, or there might be new onset of LBBB. So here there is a complete coronary occlusion will be there. So immediate reperfusion is required. NSTEMI, ST depression or T wave inversion here. So there is a death of myocytes with the release of the troponin. Okay, but there is no ST elevation. So there is a partial occlusion. So early invasive strategy is needed to evaluate further. Unstable angina, there is no persistent ST elevation, so negative troponin. So there might be ST depression, T wave inversion, but usually troponin, the cardiac enzyme, is going to be negative. It is a ischemia, not like death of the cells. There is no necrosis, there is no infarction. So it may be sometimes a pre-MI, pre-myocardial infarction state, we call it as. So this is the other way of classification of the acute coronary syndrome. Okay. So coming back to our patient, so it looks like is having a type 1 MI, because if you see the ECG, it shows ST elevation and hyperacute T waves in V2 to V4. So ST elevation is there, okay, V2 to V2, 3, V4. So then hyperacute T waves are there, okay. So ST elevation in lead 1 AVL with a reciprocal ST depression in lead 3. If you see lead 1, so and AVL, so there is a ST elevation. So lead 3, there is a reciprocal ST depression is there. So Q waves are present in the septal leads, that is V1 to V2. So there are Q waves are there. Okay, V1 to V2. So the diagnosis is, it looks like an hyperacute. So anteroseptal ST segment elevated MI. So definitely anterior MI is there. So because of the septal lead involvement, it is an anteroseptal MI. So it is a type 1 MI. So there is a plaque rupture with thrombosis. So ST elevation is there, anteroseptal involvement. So culprit vessel looks like proximal LAD territory. So again, the examiner might ask, so how you like say there is a proximal LAD involvement as a culprit blood vessel. Okay. So V2 to V4 ST elevation with hyperacute T waves, which means anterior wall ischemia is there. So Q waves in V1 to V2. So there is a septal infarction which is supplied by septal perforator of LAD. So lead 1 AVL ST elevation, high lateral extension, often with a proximal LAD involvement. Okay. So reciprocal depression in lead 3 which support high risk of anterior MI. So proximal LAD occlusion so affects septal branches, that is V1 to V2. So diagonal branches, that is 1 AVL. So anterior wall, that is V2 to V4. Okay. So next examiner will ask, what are the different ECG patterns you can see in a patient with acute coronary syndrome? So you can just quickly go through it. So there might be ST segment elevated MI. So ST elevation in more than or equal to 2 contiguous so leads. So cutoff is V2 to V3 more than or equal to 2 millimeter for men who are more than or equal to 40 year, or more than or equal to 2.5 millimeter So men who are less than 40 year. So for women, so more than or equal to 1.5 millimeter is the cutoff. So other leads, it is like more than or equal to 1 millimeter. So it indicates there is an acute transmural infarction. So example V1 to V4, that is LAD territory, antral MI. So lead 2, 3 AVF, inferior MI with a RCA or left circumflex involvement. So there is a hyperacute T wave changes. So very early STEMI can have this manifestation. Tall, broad-based symmetric T waves. So often precede the STEMI. So short-lived, easily missed many a times if you done a ECG later. So earliest ECG sign of acute MI is so hyperacute T wave, which is the preceding finding for the STEMI. So ST segment depression, horizontal downsloping ST depression of more than or equal to 0.5 millimeter. So seen in STEMI, unstable angina, reciprocal changes in STEMI or posterior MI. So it is a mirror image. Okay. Again, fourth ECG finding is T wave inversion. So deep, which should be more than or equal to 2 millimeter. So symmetric T wave inversion will be there. So it reflects myocardial ischemia. So persistent inversion. So which is the evolving infarction. Okay. So then we can have pathological Q waves. So width is going to be more than or equal to 0.04 second and depth of more than or equal to 25% on R wave. Okay. So it is a signs of established myocardial necrosis may appear within hours in large MI, that is interval MI. Okay. So sixth is new or presumed new onset LBBB. So STEMI equivalent if ischemic symptoms are present. Okay. New onset of LBBB should be considered when patient is having ischemic symptoms, or use Scarboza or modified Scarboza criteria. You can just go through this Scarboza criteria. So it is an high risk ECG pattern. So we can't neglect a new onset LBBB. Posterior MI pattern, ST depression in V1 to V3, tall R waves in V1 to V2, upright T waves. So like it confirmed with V7, V9 ST elevation. Okay. So we have something called critical LAD, that is Wellen syndrome. So it is a biphasic or deeply inverted T waves in V2 to V3. So pain-free interval will be there, normal or minimal ST elevation. So it is an impending interval MI. So like stress test is contraindicated, because if you subject the person for stress, so you might have a full-fledged STEMI and you might have a cardiac arrest. So ninth finding, right ventricular MI pattern, inferior MI, okay, inferior MI plus ST elevation in V4R. So hypotension, so lung fields are clear because of the RV contractility is poor, there is no pulmonary congestion. So here in RV infarct, we should avoid nitrates because of the inferior MI. Okay. So which may precipitate the hypotension and hypoperfusion. So these are the like pictorial ECG representation of different ECG manifestation. You can carefully go through these two things. So sometimes if your examiner is from the background of internal medicine, so he might be interested to know, or like he might go in depth asking all these questions and all. So as I told, Wellens pattern, okay, Scarboza criteria, you can just go through all these things. So it is also written the footnote. So just for completion's sake, you can just go through these two pictures. Okay. So next question is, can you comment on different ECG territory and vessel involved? So now we learned that, okay, different ECG patterns, different like classification of MI. So next question is, so in terms of the ECG involvement, and what is the correlation with that of the underlying vessel involved? Okay. So suppose if there is a involvement of the so anterior, that is V1 to V4 leads in the ECG, left anterior descending LAD territory is problem. Okay. So like if you see, this is the like V1 to V4 anterior septal involvement will be there. So lead 1 AVL V5 V6 lateral, that is left circumflex artery involvement. So this is the left circumflex manifestation. Okay. So lead 2 3 AVF is inferior MI, so right coronary involvement. So this is the territory of the ECG with the inferior MI. So V7 to V9, that is the posterior involvement of the left circumflex. Okay, that is the posterior. Okay. So basically in our patient, we have done an echocardiography which shows anteroseptal regional wall motion abnormality. So anterior, okay, and the septal part is not moving. So it is an anteroseptal severe ST segment elevated myocardial infarction. So you can have some sort of pictorial memory for understanding regional wall motion abnormality in a echo finding. Okay, so LAD territory. So if you see, this is the LAD territory. Okay, so these are all yellow color is the LAD territory. So that is the septum. Okay, interwall can be the problem. RCA, that is inferior wall. Okay, blue color is the RCA. So it is the right side heart involvement will be there. So right ventricular dysfunction is common. RCA or LAD again. So it can be septal involvement. Okay, so LAD circumflex, again the interwall involvement is common. RCR circumflex, again green. So here, so there is a possibility of the lateral wall involvement or the inferior wall involvement. Okay, so basically, so this is to understand different regional wall motion abnormality in echocardiography. So suppose in our patient who is a middle-aged male, so on ECG we got it is an ST segment elevated MI. So if at all you want to send the biomarkers, which one to send and why? So obviously high sensitivity troponin IRT, which is the gold standard. So CKMB, it is historical, but many examiners are interested to know the timeline of the cardiac markers. Okay, so it helps in reinfarction identification. So we got a troponin high sensitivity troponin I, which is 8200. So it is markedly elevated. It comes acute. It confirms the acute myocardial infarction. So like this is the table again. If you see the ECG pattern, so ST elevation, STEMI, hyperacute T wave, very early MI, ST depression, N STEMI or reciprocal changes, T wave inversion. It suggests the ischemia may not be infarction. Q wave suggests established MI. So new LBBB is STEMI equivalent we need to consider. V1 to V3 ST depression post-wall MI. Valence pattern, which is the critical LED, avoid stress test here. Okay. So next question is, can you comment on timeline of cardiac enzymes? Very, very common Viva question you can get when you have a ACS patient for the discussion. Okay. So this is the timeline of cardiac biomarkers. Again, it is a representation. So in a diagram, so myoglobin is the initial to rise, first to rise in 1 to 2 hours. So peak in 6 to 9 hours. So return to normal, so in 24 hours. So this is the myoglobin peak. So it is the earliest marker, but low specificity, highly sensitive, so less specific value. CKMB, next 3 to 6 hours, peak in 18 to 24 hours, 48 to 72 hours, it returns to normal. Useful to get an idea about the reinfarction. Okay, so CKMB, so it get normalized in 48 to 72 hours. So troponin I in the next 3 to 6 hours. So that's why if you done a trope within 3 hours, it may not be elevated. So peak in 24 to 48 hours. So return to normal in about 7 to 10 days. So it is a gold standard for the diagnosis. So if you done a troponin T, which follows the same pattern, okay, persist little longer, that is 10 to 14 days, which helps in both prognosis and diagnosis. Okay, LDH, nobody does the LDH for MI nowadays. So initial rise 12 to 24 hours. So peak in 2 to 3 days. Okay, return to normal in 7 to 14 days. Rarely used nowadays. So this is the LDH pattern. The take home here, so troponin elevation suggests myocardial injury, but not always is the diagnostic of myocardial infarction. There are other reasons for troponin to rise. So normal early troponin does not rule out the MI if it is within 3 hours. So repeat testing is needed after 6 hours. So CKMB is useful for detecting reinfarction. Myoglobin is the earliest but less specific biomarker of the cardiac origin. Again, these are some of the false positive, false negative which you can go through. So one common exam based question they are going to ask is, what are the false positive reason for rise in troponin IRT? So CKD patients, sepsis, septic shock patients, pulmonary embolism, myocarditis, heart failure, tachyarrhythmia, so cardiac contusion are secondary to trauma, post cardioversion, post ablation therapy, subarachnoid hemorrhage, head injury, high dose catecholamine, can all these kick off false positive troponin. So we have cerebral troponin in a patient who is having pathology in the brain. So false negative. So MI is there but normal value. If you done the value of the trop less than 3 hours, or patient is having a very small infarct, so rapid reperfusion you have done, like within 3 hours only you have done PCI thrombolysis. So improper timing of the sample, sometimes analytical or lab error may be the false negative reason for the troponin. So this column is very, very important. Okay, you can just go through it at least for the troponin I and T for false negative and false positive reasons. So next is, so coming back to the patient management. So what is the immediate management in the ED, emergency department, will do? Okay, if you see in the immediate 10 to 15 minutes is very, very life saving. So we need to target certain therapies on a priority basis. So monitoring access, okay, cardiac monitor you attach. So IV access at least two. So like, which helps in detecting malignant arrhythmias if you monitor the continuous ECG for this patient. So supplement the oxygen, only target to maintain more than 94%, because hyperoxemia so is going to have a worse outcome. So there is no indication for routine oxygen, but if it is less than 94%, you can supplement the oxygen. So antiplatelet, aspirin, chewed aspirin is life-saving. So 300 milligram stat. So according to ICIS-2 clinical trial, which reduced the mortality by about 23%. This is one of the like strategy which helps in reducing the mortality. So second antiplatelet, either a ticagrelor or clopidogrel. So 180 milligram of ticagrelor or 300 to 600 milligram of clopidogrel. So dual antiplatelet therapy is mandatory. Anticoagulation with an unfractionated heparin or enoxaparin or fondaparinux. So as per the weight or renal function, it helps in preventing so thrombus propagation. Okay. So analgesia. So if there is a severe ongoing pain, then only you can use the IV morphine. So 2 to 4 milligram IV titrated, which helps in reducing the pain, and it also helps in reducing the sympathetic drive. So, but you need to use cautiously. Nitrates, sublingual or IV glyceryl trinitrate, only if systolic blood pressure is more than 100, but if patient is having hypotension or if there is a right ventricular MI, inferior MI, avoid nitrates. Okay. So high intensity statin, atorvastatin or rosuvastatin. So usually atorvastatin 80 milligram stat, so which helps in plaque stabilization, and it is also having some pleiotropic action. So with the anti-inflammatory property. Beta blockers only in selected patient. That to oral beta blocker, don't give IV. If you give IV, there is a precipitous fall in blood pressure. So not to given when patient is having shock or severe heart failure with hypotension or bradycardia. So IV beta blockers increase the mortality in shock. So that is contraindicated. So reperfusion strategy, very, very important. You need to plan. So either primary PCA or thrombolysis. If the door to balloon time is less than or equal to 90 minutes, so then you can straight away take for PCI if you are having a cath lab with a PCI facility. So time is equal to myocardium. So it is very, very important in acute coronary syndrome. Okay. So next, in depth on antiplatelets, anticoagulation. Okay. So next is thrombolytic agents. So glycoprotein 2b3 inhibitors, your Viva can land you in a trouble if you don't know all these things. Okay. So next, the evidence and dosing of antiplatelet aspirin. So according to ICIS-2 trial, 300 to 325 milligram chewed aspirin. So with a maintenance dose of 75 to 150 milligram OD, so definitely helps in reducing mortality by about 23%. So additive benefit when you combine aspirin with thrombolysis. Okay. So clopidogrel, we got cure, commit and clarity trial. Somewhere the dose is 300 to 600 milligram with a maintenance dose of 75 milligram. So it helps in reducing the recurrent MI, stroke, cardiovascular related death when added to aspirin. So ticagrelor, we got a plateau trial, 180 milligram loading dose followed by 90 milligram BD. It is superior to clopidogrel in reducing cardiovascular death and myocardial infarction. So there is no overall increase in the major bleeding even if you use the ticagrelor. Okay. So next is duration of therapy. So very, very important. When patient add a STEMI with PCI with, okay, so then better to give so lifelong therapy if the patient is having a drug eluting stent. Okay. So that is aspirin lifelong, at least P2Y12 inhibitor duration is 12 months. That is the dual antiplatelet therapy. So STEMI who underwent thrombolysis lifelong for aspirin. So minimum 12 month for P2Y12 inhibitor, that is clopidogrel or ticagrelor. So NSTEMI, unstable angina. So medically managed or PCI, again aspirin is lifelong, and other dual antiplatelet add-on therapies for 12 months. So high bleeding risk, aspirin should be for lifelong. There is no compromise. So 3 to 6 months at least you should get the dual antiplatelet. Post CABG for ACS, again aspirin lifelong. So up to 12 months you should consider to give like dual antiplatelet. Okay. So the take home message, aspirin is lifelong unless So absolutely contraindicated. Dual antiplatelet at least for 12 months in ACS. Okay. So ticagrelor is preferred over clopidogrel in ACS if no contraindication. So clopidogrel preferred if there is a high risk of bleeding, prior intracranial hemorrhage is there. So need for oral anticoagulation. Then in that scenario can go for clopidogrel. Okay. Is there any role for glycoprotein 2b3 inhibitor? So they also helps in preventing the thrombus formation, but is it routinely indicated for all the patients or in which patient we give? Okay, if we see glycoprotein 2b3 inhibitors, we have apixaban, eptifibatide and tirofibin. So like apixaban is a monoclonal antibody, so it is a irreversible glycoprotein 2b3a inhibitor, so indicated in high risk ACS undergoing PCI. So large thrombus burden is there, or sometimes as a bailout therapy during PCI. So there is no reflow or thrombotic complications are there, then we can use the apixaban. Standard dosage 0.25 milligram per kg IV infusion. Okay. So bolus is 0.25 milligram per kg IV followed by infusion of 0.125 mics per kg per minute. So maximum 10 mics per minute we can use. Okay. Duration 12 hours post PCI. So not renally cleared. Okay. So that you need to remember high bleeding risk. So rarely used now, that is the apixaban because of the bleeding risk. So next is eptifibatide. So it is a reversible glycoprotein 2b3 inhibitor. It is a peptide molecule. So indicated in high risk NSTEMI, planned for early invasive strategy, STEMI during PCI with a high thrombus load. So dose bolus of 180 mics per kg. So two doses. So 10-minute apart, infusion of 2 mics per kg per minute. So duration is 18 to 24 hours. Okay. So reduce the dose if create clearance is less than 50. Avoid if the patient's platelet count is less than 1 lakh. So tirofibin, again it is a reversible glycoprotein 2b3 inhibitor. It is a non-peptide. So indication in NSTEMI with ongoing ischemia, bailout therapy during PCI, large intracoronary thrombus is there. Dose bolus of 25 mics per kg, IV over 3 minutes. So infusion of 0.15 mics per kg per minute. So duration is around 18 to 24 hours infusion. Okay. So again, renal dose adjustment is needed. So commonly used in cath lab, that is the tirofibin. Okay, the take home. So glycoprotein 2b3 inhibitors are adjunctive antiplatelet agents used selectively in high risk ACS patients undergoing PCI, mainly as bailout therapy, and are not used routinely in the modern dual antiplatelet era. So remember, they are not a replacement for antiplatelet, they are a adjunctive for the antiplatelet. So can you comment on the duration and selection of anticoagulations, anticoagulant agents in acute coronary syndrome? So these are all your Viva questions. There is no way, so you are going to present your ACS case without knowing all these things. Okay. So we have, so unfractionated heparin dosage of 60 to 70 units per kg bolus. So maximum of around 4,000 to 5,000 units. Infusion of 12 to 15 units per kg per hour. So with a APTT of around 2 to 2.5 time maintenance. So primary PCI, cardiogenic shock, renal failure, we prefer so unfractionated heparin. So it is having a rapid onset, short half-life and reversible with the protamine. So enoxaparin, which is a low molecular weight heparin, 1 milligram per kg subcutaneous 12th hourly. So once daily is indicated if clearance is less than 30. So it is indicated in STEMI with thrombolysis or maybe in NSTEMI. So more predictable pharmacokinetics as compared to unfractionated heparin. So it helps in reducing the reinfarction incidence. Okay. Fondaparinux use at a dose of 2.5 milligram subcutaneous OD. Okay. So NSTEMI, unstable angina. So who require medical management, we can go for fondaparinux. So it decrease the bleeding risk, not used alone in PCI patient. Okay. So again, fondaparinux is a weight-based therapy. So we need to go for 5 milligram, like 7.5 milligram, 10 milligram, depending upon the weight of the patient. So bivalirudin, so we follow with a bolus plus infusion. So in the PCI setting, so use it for PCI, primary PCI patient. So decrease the bleeding as compared to heparin plus glycoprotein 2b3 inhibitor. So dual anticoagulants means direct oral anticoagulants. Okay. So Novax or Dovax. So currently evidence is evolving. So it is one indication where we don't prefer for all the patients with all available direct oral anticoagulants. But if at all you want to use rivaroxaban at a dosage of 2.5 milligram BD in a selected cases, post ACS, selected low bleeding risk patient we can use, not routine in the acute phase. We need still more data because high risk of bleeding when you use direct oral anticoagulants. So duration of anticoagulants in acute coronary syndrome, STEMI with a thrombolysis minimum 48 hours. So usually up to 8 days or until PCI. Otherwise 48 hours is needed. STEMI with primary PCI. So during the procedure we need anticoagulation. So plus or minus short post procedure we might require. So NSTEMI unstable angina who managed with medical management. So up to discharge, okay, maybe 4-5 days you are discharging or maximum of 8 days. So atrial fibrillation if a patient had or LV thrombus, so then we need 3 to 6 months of therapeutic anticoagulation. So sometimes they need a oral anticoagulant on a maintenance. So high bleeding risk, so shortest effective duration is okay, maybe like 3 days like that if the patient is having a high risk of bleeding. So again, what is the evidence supporting anticoagulation in ACS? So unfractionated heparin. So these are the early ACS trials, okay, which shows decrease in thrombus propagation and decrease in reinfarction rate. So enoxaparin, the data is from Essence trial, TIMI 11B trial, which showed reduction in mortality and so non-fatal MI as compared to unfractionated heparin. So it's a comparative study. Okay. So fondaparinux, we have OSS 5 trial. So similar ischemic protection with decrease in the major bleeding risk as compared to unfractionated heparin. So bivalirudin, so Horizon AMI trial. So it help in reducing major bleeding in PCI patients. Okay. So low dose direct oral anticoagulant with a rivaroxaban. So that is Atlas ACS2 trial. So it decreases the ischemic events, but the problem is with the increase in bleeding risk. The take home, so anticoagulation is mandatory in ACS patient in addition to dual antiplatelet. So enoxaparin is preferred in thrombolysis treated STEMI or NSTEMI. Unfractionated heparin is preferred in PCI patients, so shock or renal failure patient. Fondaparinux is safest for bleeding but needs unfractionated heparin, so definitely during the PCI procedure. So duration is short term, unlike antiplatelet that is aspirin needed for the lifelong. So these are the take home messages on the anticoagulation therapy. Okay. So back to our case. So emergency department. So we diagnosed anterval MI and we done initial some sort of therapeutic option investigation in the ER itself. Okay. So in the ED, patient was placed on continuous cardiac monitoring. So oxygen therapy was initiated to maintain SpO2 somewhere more than 94%. Aspirin we given 300 milligram. So like we started on dual antiplatelet with a ticagrelor 180 milligram as a loading. So otherwise we can go for clopidogrel 300 to 600 milligram also. So therapeutic anticoagulation with enoxaparin 1 milligram per kg. So 12th hourly subcutaneous we added. So high intensity statin therapy we given atorvastatin 80 milligram orally. So adequate analgesia was provided. So while nitrates were withheld because patient was already having a borderline blood pressure. So next question, very important question is, patient is having STEMI now, okay, anteroseptal MI. What are your definitive reperfusion strategy you want to do for this particular patient? What are your timeline? So basically, okay. So timeline for reperfusion therapy, if you see, first medical contact, so you should do the ECG within less than or equal to 10 minutes. So door to needle for thrombolysis, okay, less than or equal to 30 minutes you need to plan. Door to balloon, if you have a facility for PCI, so it is like less than or equal to 90 minutes. That's the primary PCI. So first medical contact to device, that is PCI capable, if you are planning to shift, that is up to less than or equal to 120 minutes. Okay. So basically, so STEMI reperfusion therapy, so PCI capable center, so delay is less than or equal to 90 minutes. So preferably go for primary PCI, that is the class 1 gold standard reperfusion therapy. PCI is delayed beyond 120 minutes, so then go for thrombolysis. So early thrombolysis saves the myocardium. So if patient is having a cardiogenic shock, so primary PCI is indicated. Okay, any delay is okay, but you need to plan for primary PCI. So survival benefit is going to be good with primary PCI. So failed thrombolysis, we can go for rescue PCI, that is mandatory. So thrombolysis is successful. So then also you can consider in the next 2 to 24 hours as a pharmacoinvasive PCI with a better outcome. So late presenter beyond 24 hours and they are stable, there is no routine reperfusion, then we can plan for angio later, and so consider some modality of the plasty or stent in the later date if they present more than 24 hours and they are clinically stable. Okay, so these are the therapeutic options for thrombolytic agents. So their dosage, administration, and key features. So we have tenecteplase. So it is a weight-based single bolus. That is one of the advantage. So less than 60 kg, 30 milligram, 60 to 70 kg, 35 milligram, 70 to 80 kg, 40 milligram, 80 to 90 kg, 45 milligram, more than or equal to 90 kg, 50 milligram. Single IV bolus over 5 to 10 seconds. Very fantastic. Okay. Most preferred thrombolytic agent is tenecteplase, which is fibrin specific, lowest non-intracranial hemorrhage bleeding risk, ideal for pre-hospital or even in Indian setting. Okay. Alteplase, so 15 milligram IV bolus we give, then 0.75 milligram per kg, that is maximum dosage of 50 milligram over 30 minutes, then 0.5 milligram per kg, again maximum of 35 milligram over 60 minutes, total of maximum 100 milligram we give. So IV infusion over 90 minutes is the therapy with so alteplase. Okay, again here also it is fibrin specific, but the higher risk of bleeding as compared to tenecteplase, so which is the infusion based bleeding. So riteplase, so 10 units IV into 2 dosage with the 30 minutes apart as IV bolus we give. So easy bolus dosing is possible, so but it is less commonly used. Streptokinase, 1.5 million units, so infusion over 60 minutes. So it is a fibrin non-specific. Okay, increased risk of hypotension, allergy. Even though it is low cost, there is an increased risk of the bleeding. So the take-home message, so tenecteplase is preferred due to single bolus dosing and better safety profile. Okay, so alteplase require weight-based infusion and close monitoring. So streptokinase should not be used, especially if they are already pre-used. So then don't reuse it because of the antibody formation. So the efficacy is going to be reduced. So always combine fibrinolytic therapy with the antiplatelets under of the anticoagulation. So that's about the thrombolytic options. Okay, again, so if you see the reperfusion strategies in terms of the evidence for primary PCI, we have multiple meta-analysis which shows reduction in mortality, reduction in reinfarction rate, and reduction in stroke risk. So Dynami 2 trial, so which shows PCI is superior to thrombolysis. So there are other like some sort of the pooled data which shows delays the worsening up of the mortality. Thrombolysis, we have ICIS-2 trial. Suppose if you club thrombolysis with an aspirin, there is a definitive reduction in the mortality. Okay, so that is with aspirin and thrombolysis. So GISC-1 trial, early thrombolysis saves the life. So Indian TNK tenecteplase studies, it is safe and effective in Indian STEMI to use the tenecteplase. So pharmaco-invasive strategy, we have STREAM trial. So thrombolysis plus early PCI, okay, is almost equivalent to that of the primary PCI efficacy. So contemporary guidelines also suggest preferred when PCI delay is there. So okay, we can thrombolyze and we can go for the invasive strategy as a pharmaco-invasive strategy. So, but once we done reperfusion therapy, like thrombolysis, for example, how to assess the successful of the reperfusion, whether it is helping or not. So, there should be more than or equal to 50% ST segment resolution. So, in the next 60 to 90 minutes, so there should be relief of the chest pain. So, reperfusion arrhythmia, what we call it as accelerated idioventricular rhythm should be there. Early peaking of cardiac enzyme, so should be there. Okay. So when PCI is clearly superior to thrombolysis in certain conditions, like when patient is having cardiogenic shock, severe heart failure, mechanical complication, when there is an absolute contraindication for thrombolysis. So or if a patient is a late presenter with an ongoing symptom of the ischemia, we can go for PCI. Okay. So back to our patient. So thrombolysis is done. So day 1 patient is in ICU. Patient underwent pharmacological reperfusion with a weight-based tenecteplase. So in the emergency department itself, shifted to ICU for continuous hemodynamic and rhythm monitoring. Okay. So day 1 of ICU, his heart rate is around 96 per minute. BP is around 104 by 66. MAP is around 78. So respiratory rate 22 per minute, saturating with the 3 liter around 96%. urine output is 0.6 ml per kg per hour. So it's been started on low dose norepinephrine at a dosage of 0.0 mics per kg per minute to maintain the map of more than or equal to 65. So we done an ABG, it looks okay. pH is 7.36, PCO2 38, PO2 92 and 3 liter of oxygen, bicarb is 22, lactate 1.8. Fairly, the condition looks under control on day 1. Okay. So day 2, there is a clinical deterioration. Patient developed progressive hypotension. There is signs of low cardiac output. Okay. So his vitals deteriorated. Heart rate is 118. So blood pressure is 86 by 52. MAP is 55 to 58. So cold peripheries, patient started having altered sensorium. His NARAD requirement increased to 0.25 mics per kg per minute to maintain the perfusion. Urine output dropped to 0.3 ml per kg per hour in the last 6 hours. So ABG shows lactate of 5.6, base excess is -10. So bicarb is 14, PO2 is 78, PCO2 is 32. So pH is 7.24. Okay. So what we thought, anyhow is deteriorating. So we thought we go for one of the advanced hemodynamic monitoring, that is flow track Vigilio monitor from Edwards we put. So we need only one radial artery line for this. It is a non-calibrated device, okay, which gives cardiac output on the analysis of the arterial waveform. Okay, so that doesn't require any sort of cold saline injection for calibration. So it is not a thermodilution based method. So that taken into consideration of the arterial waveform for giving the continuous cardiac output monitoring. Okay. So when we put his cardiac output is 2.4. So cardiac index is 1.3, stroke volume 38, stroke volume index is 21. So MAP is around 56. So heart rate which is around 118. So systemic vascular resistance is 1850, SVRI is 2950. Okay, SVV stroke volume variation is 8%, pulse pressure variation is around 7%. Okay, so next the question here is, so like how to interpret this data? So we put this flow track. So comment on these values. What's happening here? If you see patient is having a low cardiac output, low cardiac index, low stroke volume and stroke volume index, which suggest severe low cardiac output stat secondary to cardiogenic shock physiology, high systemic vascular resistance or SVRI, which is a compensatory vasoconstriction with increase in afterload. Okay, MAP is low, which suggests inadequate organ perfusion. So can we rely on SVV or PPV for getting an idea whether we can give a fluid here, patient is fluid responsive or not? So remember, patient is on spontaneous breathing. So answer is no. In spontaneous breathing, or when patient is having a arrhythmia, when patient is on mechanical ventilation with less than 8 ml per kg of the tidal volume, okay, or when patient is having severe RV dysfunction, severe ARDS, so we can't rely on SVV or PPV, okay, even though they are the dynamic indices. So these are the restriction we can't relay. Here patient is on spontaneous breathing, we can't relay. So remember, these kind of questions examiner's favorite. Okay, don't think your Viva is going to be very straightforward. It can jump to hemodynamic monitoring. So next bedside test, test is we can go for PLR. So with a real-time cardiac output, that is flow track already is there. So if like there is an increase in like stroke volume or cardiac output by more than 10%, which means like patient is like fluid responsive. So we need to measure the baseline cardiac output and do the PLR. Then there should be increase by 10% at least. So then which suggests the fluid responsiveness. Okay, how to do PLR? That is the next question. So you should start from the 45-degree. So head elevation, that is a semi-recombinant position. Okay, it makes that like the venous return is going to be adequate, at least of 300 ml to challenge the system. Okay, next use the bed adjustment. Remote operating bed should be there. Don't touch the patient. There should not be any painful stimuli. So then elevate the like leg end for about 45-degree. Assess PLR effect by directly measuring continuous cardiac output. So not with blood pressure or heart rate change. Okay. So then like real-time cardiac output monitoring is very essential. So reassess the cardiac output like at the end of 1 minute, at least 30 to 90 seconds, we are going to assess the change in cardiac output. One baseline we measure. So after legend elevation at the end of 1 minute, so we measure one more cardiac output. So reassess the cardiac output in semi-recombinant position. So whatever the cardiac output was there baseline, when you go back to the original position, so then it should revert to the same cardiac output value. So that is the full cycle of your passive leg raise. If there is an increase in cardiac output or stroke volume by about at least more than or equal to 10%, so then patient is volume responding. Okay, so this is how you are going to perform like PLR. Very, very important. Okay, so we done a PLR, post PLR. These are the values of the flow track. So his cardiac output become decreased. So it is 1.9 now. So cardiac index is 1. Stroke volume is also reduced. Initially, if you see, it was around 38, say 38, and SVI is 21. Both are decreased now. It become 28 and 15. So other parameters fairly in and around the same. Is he responded to volume? No. On the other hand, so there is a worsening of cardiac output and that of the stroke volume. So stroke volume falls from 38 to 28. So by about 26% reduction in stroke volume is there. So cardiac index, cardiac output also decrease. MAP, there is no improvement. So PLR is negative, is not fluid responsive. What we need to do? So like his cardiac output is not preload dependent, it is preload independent. So we need to go for escalation of vasoactive therapy like inotropes, or maybe like we need to opt for the some sort of mechanical support for the cardiogenic shock, which is the complication of severe anteroseptal MI. Okay, so this is the post thrombolysis ECG. So patient is still deteriorating. What's happening here? If we see the echo is hardly contracting, the LV is very, very poorly contracting. So this is the ECG finding in the post thrombolysis period. Okay, what's happening here? If you see a patient with severe anteroseptal MI post thrombolysis with tenecteplase, so he's having a persistent ST segment elevation in the ECG. There are persistent ST segment elevation which suggest so there is ongoing ischemia is there with a worsening hypotension, rise in vasopressor requirement, increase in lactate and oliguria. These are the perfusion markers. So the most likely diagnosis is failed thrombolysis, failed reperfusion therapy. Okay, what further management we need to do? So there is a failed thrombolysis with an ongoing myocardial infarction, that is the diagnosis is here. So is having a cardiogenic shock secondary to extensive anteroseptal MI. So this represent an indication for rescue PCI. Okay, what we call it as pharmacoinvasive therapy, rescue PCI. First we done pharmacological, so reperfusion with thrombolysis, it is not helping, then we go for the PCI. So persistent ST elevation more than 50%, non-resolution at 60 to 90 minutes, along with unstable hemodynamics, it suggests an unsuccessful reperfusion. So we need a PCI like as a rescue therapy with continued dual antiplatelet therapy and anticoagulation. So we need to support the hemodynamics to maintain the adequate mean arterial pressure of around 65. So urgent coronary angio is needed, okay, with like either some sort of stenting or angioplasty. But in the meanwhile, so for supporting the hemodynamics, he might require some sort of mechanical circulatory support, maybe IABP, Impella, or veno arterial ECMO, if there is a persistent like hypoperfusion. Okay, that should be your answer. So failure of thrombolysis is defined as less than 50% of ST segment resolution in 60 to 90 minutes, or there is an ongoing chest pain, unstable hemodynamics, or electrical instability is there. So rescue PCI is the class 1 recommendation in failed thrombolysis. Cardiogenic shock is an absolute indication for invasive revascularization, so irrespective of the time delay. So that is the take home message. Okay, so what are the mechanical complications you expect in a severe interval MI? So one problem is pump like already gone, that is a cardiogenic shock. Other than this, what are other mechanical complications? That is one of the important viva question. Okay, so we can expect like papillary muscle rupture somewhere in 2 to 7 days, peak of around 3 to 5 days. These are the timeline of mechanical complications. So acute severe mitral regurgitation, which is the ischemic, 2 to 7 days. Ventricular septal rupture with VST, 3 to 7 days. So left ventricular free wall rupture, 3 to 7 days, can be earlier also. Pseudoaneurysm of LV, somewhere days to weeks. Weeks to months we can get true LV aneurysm. Acute pericarditis early 1 to 3 days. So post-myocardial infarction syndrome, what we call it as Dresser syndrome, that is 2 to 6 weeks. So like LV mural thrombus 3 to 14 days. So these are the, so some sort of mechanical complication. So next table is very, very important. Suppose if a patient is having a pulmonary artery catheter, that is Fansgans catheter, how you find the manifestation with a mechanical complication. Assume patient is having a papillary muscle rupture. So with a severe acute severe MR, you will have markedly elevated pulmonary capillary wedge pressure with a gained V waves in the like PA catheter waveform. So normal or mildly elevated pulmonary artery pressure initially, so decrease in cardiac output. So gained V waves are pathognomic. So sudden pulmonary edema with hypotension is a clinical manifestation if they have capillary muscle rupture with a severe MR. So ischemic acute MR without the rupture, again pulmonary capillary wedge pressure with raised with a prominent V waves. So moderate pulmonary artery hypertension, decrease in cardiac output. So it is a less dramatic than rupture, but similar pattern of clinical finding. So ventricular septal rupture with a VST post MI. So there is a step up in oxygen saturation from RA. Okay, so there is a RV to PA. So which means, so when patient is having a ventricular septal defect, so there is a shunting of oxygenated blood from the left ventricle toward the right ventricle. When you measure oxygen saturation in the pulmonary artery tip, so there like saturation is going to be increased. It is almost similar to that of the systemic oxygen saturation. So that is one of the very, very important finding for VSD because of the left to right shunt. Hallmark is oxygen saturation step up, we call it as. Okay, so there is an increase in pulmonary artery pressure, increase in capillary wedge pressure with a decrease in cardiac output. So left ventricular free wall rupture with a tamponade. So there is a rise and equalization of the diastolic pressure. So right atrial pressure, right ventricular end diastolic pressure, and pulmonary artery occlusion pressure. So there is a decrease in cardiac output. So elevated right atrial pressure. If you done an echo, which shows diastolic collapse of the RA and RV. Okay. So there is a sudden pulseless electrical activity. So because of the tamponade physiology, patient can have. So right ventricular infarction, there is an increase in right atrial pressure, normal or low pulmonary artery occlusion pressure, because it is not the LA problem or LV problem which put a back pressure on pulmonary artery. So it is a problem in the RV. RV is not able to contract. So low cardiac output. Lung fields are very clear. Pulmonary oligemia with a normal or reduction in pulmonary artery occlusion pressure with increase in right atrial pressure, that is a CVP. So with low cardiac output suggest right ventricular infarction. True LV aneurysm, late manifestation, increase in LV filling pressure, decrease in cardiac output. So normal shunt values, okay, it is a chronic heart failure physiology is going to be there. So cardiogenic shock, that is LV failure, increase in left ventricular increase in pulmonary artery occlusion pressure, decrease in cardiac output, cardiac index. As a compensatory mechanism, there is an increase in SVR. So most common post anterior wall MI complication is cardiogenic shock. So the take home, gained V wave, acute MR. Oxygen saturation step up, post MI VST. Equalizer pressure, tamponade with a free wall rupture. High right atrial pressure, low pulmonary capillary wedge pressure with pulmonary oligemia, RV infarction. So PA catheter helps in differentiating shock phenotype, but not just to diagnose the shock. Okay, so we have some sort of more invasiveness when we put the PA catheter, but these are some of the typical findings of PA catheter which can be your Viva question. So next move on little bit in and around vasoactive agent option for acute coronary syndrome. Okay, so which vasoactive agent would be most appropriate as first line support in this patient while awaiting mechanical circulatory support? What is your physiological rationality? So the clinical context is patient is having a cardiogenic shock with a low MAP, low cardiac output, high SVR, so not fluid responsive because PLR is negative, who is awaiting for some mechanical support, which we initiated with the IABP. So vasoactive strategy at this stage, so start or optimize with a norepinephrine as a primary vasoactive agent. So aim to restore MAP of more than or equal to 65 while helping in preserving the coronary perfusion. So use as a bridge to mechanical circulatory support. So rationality, pros and cons of agents. Norepinephrine, it acts on predominantly alpha 1 receptor with increase in SVR and MAP. So mild beta 1 support. So the benefits are improve in MAP, coronary perfusion pressure, minimal tachyarrhythmia risk as compared to dopamine. So first line vasopressor in cardiogenic shock. Cons does not significantly increase the cardiac output, so not a pure ionotropic agent. Okay, dobutamine, if you see, it acts on beta 1 more than that of the beta 2. Through the beta 2, it can cause peripheral vasodilatation, drop in blood pressure, so worsening hypotension, reflex tachycardia because of increase in myocardial oxygen demand with increase in tachycardia. So roll only when we stabilize the map, then we can use the dobutamine. So if patient is hypotensive, it is not an option. Dopamine, it acts on alpha, beta and D receptor. So little bit dose dependent, but there is no clear cut margin for this. So like high risk of tachyarrhythmia, increased mortality in cardiogenic shock. So even in SOAP 2 trial, there is a problem. It is not recommended. So milrinone, it is a phosphodiesterase 3 inhibitor. It is an inodilator. The cons are, so because of vasodilatation, significant systemic vasodilatation, hypotension, especially it may worsen the shock. So long half-life, again, it is a renally cleared when patient is having AKI, we can't use milrinone. So avoid in hypotensive cardiogenic shock. So levosimendan, again, it is a calcium channel sensitizer and potassium ATP channel opener. It is also vasodilator. So with prolonged active metabolite, it can cause hypotension. So difficult to titrate the therapy when you give levosimendan. Again, here it is not suitable because patient is having a significant hypotension. The final take home. So in hypotensive, non-fluid responsive cardiogenic shock, so norepinephrine is the first line of vasoactive agent to restore the map and coronary perfusion while awaiting some sort of mechanical circulatory support. So pure or vasodilatory inotrope should be avoided until blood pressure is stabilized. Once MAP is more than or equal to 65, so we can consider adding a low dose of dobutamine cautiously for improving contractility. If refractory, then we need to go for mechanical circulatory device with IABP impella or veno-arterial ECMO. So further clinical course, so we done a angio which shows critical proximal LAD occlusion. LAD stent was performed successfully because patient is having a low cardiac output state with increase in ongoing vasopressor support. So is being considered for IABP, shifted back to ICU with advanced hemodynamic monitoring with IABP. Okay, so immediate post IABP is heart rate 98, blood pressure improved to 112 by 70, MAP is 82, norepinephrine requirement reduced to 0.12 mics per kg per minute. So oxygen saturation on 3 to 4 liter of oxygen, it is around 97%. So peripheral perfusion improved with warm extremities and better capillary refill. In the next 24 hours, okay, patient showed a gradual hemodynamic stabilization, heart rate improved, blood pressure improved, MAP consistently more than 70, urine output is more than 0.6 to 0.8. Okay, vasopressor support was gradually tapered with stable hemodynamics. Okay, little bit discussion on the IABP. So this is the IABP screen. So comment on this IABP waveforms. So what is the current evidence on the usage of IABP in cardiogenic shock? Very, very favorite Viva question. Okay. So this IABP waveform demonstrate so correct ECG trigger, that is 1:1 counter pulsation with effective diastolic augmentation and appropriate systolic unloading. It is consistent with the optimal mechanical circulatory support. Okay. So this IABP waveform is 1:1 with a good diastolic augmentation, okay, and systolic, like some sort of deflation is happening with improvement in the coronary perfusion and reduction in the afterload. Okay, so if we see the like landmark trial, IABP shock 2 trial 2012 and 2013, it is a long-term 6-year follow-up study. It is a multi-centered RCT in like severe, so acute MI with cardiogenic shock patient. Early revascularization was done. There is no reduction in 30-day, 12-month or 6-year mortality with IABP versus no IABP. It is an NEGM published data. So routine IABP not shown to improve survival benefit. So there is no evidence so base for use in cardiogenic shock. So in routine practice. Okay, meta-analysis 2015. So with MI, with or without cardiogenic shock, IABP did not improve the mortality. Again, one more meta-analysis with a 9 major study included. Again, no improvement in 30-day survival. So in cardiogenic shock or left ventricular ejection fraction who are having a low. Okay. So basically the take home message, landmark randomized evidence, especially IABP shock 2 trial and RCT meta-analysis shows that routine IABP use in cardiogenic shock. So complicating MI does not reduce the mortality, which leading to downgraded guideline recommendation. Only observational data suggest possible hemodynamic benefit. So in selected patients, but are not definitive. Okay. So next question is, can you comment on some prognostic marker risk stratification in acute coronary syndrome? At least you need to remember 2 3 on this, like Grace, Timmy, Clips, okay, so and Crusade, but there are many are there. You can just go through it. So Gray score can be used in unstable angina, NSTEMI or STEMI. It include age, heart rate, SBP, creatinine, Clip class, ST deviation, troponin and cardiac arrest data. So it tells about in-hospital and 6 months mortality. It is gold standard prognostic score. It guides early invasive strategy. We have STEMI score mainly for unstable angina and NSTEMI. It includes age of more than or equal to 65, more than or equal to 3 CAD risk factor, known CAD, aspirin use, ST deviation, current angina and troponin value. It tells about mortality, myocardial infarction, and it also tells about the revascularization requirement. So it helps in risk stratification. So it tells whether patient need invasive strategy or medical management. Okay. So like that we have a TIMI STEMI risk also. So it tells about the 30-day mortality. It is a quick bedside mortality indicator. So KILIP classification mainly for STEMI. So clinical signs of heart failure. Based on that we have categorization of KILIP. So in hospital mortality we can get. So it is another immediate bedside prognosticating indicator. For Crusade score, that is in unstable and NSTEMI, it use hematocrit, create clearance, heart rate, SBP, chronic heart failure, diabetes mellitus, vascular disease. It tells about the major bleeding. So it helps in bleeding risk assessment with the antiplatelet and mainly anticoagulants. Okay. So just remember at least Grace, Timmy, Timmy for STEMI, Clip and Crusade. Okay. So why risk stratification is needed in ACS? So it helps to predict the mortality and major adverse cardiac events, decide on early invasive or medical management, guide the ICU versus ward level of care, and it also helps in prognostication and counseling up of the patient's relatives. Okay. So again, where to use, which one to use, you can just go through it. Okay. So in the ED, in NSTEMI, unstable angina, STEMI, okay, STEMI for mortality estimation. So you can just go through this table for summarization. So in acute coronary syndrome, risk stratification should be dynamic. So combining clinical status using CLIPS classification, ischemic risk either use Grace or TIMI, and bleeding risk using Crusade. So at least these 3 4 you should remember to guide in the management strategy. Again, this is the slide which shows CLIPS classification, TIMI, STEMI risk, and that of the Grace score. You can just go through these like just for your like Viva purpose. Okay. So further clinical course, so IABP, weaning and step down, what happened subsequently? So there is a significant hemodynamic recovery in the next 24 to 48 hours. Cardiac output improved, systemic perfusion improved, NARAD completely weaned off, no hypotension, no arrhythmia. So we weaned the IABP gradually from 1:1, 1:2 and stopped as a standby. So MAP is more than 70, IABP is successfully removed. So no some sort of limb ischemia or any sort of bleeding after removal. So post IABP vitals, heart rate 76 to 80, BP 124 by 76, MAP is somewhere 70 to 78 to 85. So saturating 98% on room air, warm peripheries, good capillary refill. Okay. So ABG is also improved. So renal and other end organ perfusion with a good urine output of 1 to 1.2 ml per kg. So cardiac status, no recurrent chest pain, no further ventricular arrhythmia. So we done a repeat echo, LV systolic function is improving. So no new mechanical complication with a stable, some sort of ischemic mild MR is there. Okay. So the last Viva question here is, so what is the long-term plan for this patient? So it is very important. So this is going to be asked in your exam. So what advice you are going to give at the discharge? Okay. So these are the long-term therapeutic options for ACS. Aspirin, okay, 75 to 150 milligram. So for lifelong. Okay. So clopidogrel, ticagrelor, that is a P2Y12 inhibitor, clopidogrel 75 or OD, or ticagrelor 90 BD for 12 months. This is the standard therapy. High intensity statin, atorvastatin 40 to 80 or rosuvastatin 20 to 40, lifelong. Beta blocker, metoprolol or bisoprolol, again at least for 3 years, lifelong if LV dysfunction is there without any hypotension. AC inhibitor, angiotensin receptor blocker like ramipril, enalapril, losartan, which prevents LV remodeling, helps in reduction in heart failure and mortality. Lifelong when they have a EF of less than 40, diabetic and hypertensive. Okay, so mineralocorticosteroid receptor antagonist like eplerenone, spironolactone, which helps in reduction in mortality in LV dysfunction with heart failure or diabetes. So when EF is less than or equal to 40%, we can keep it for lifelong. So anticoagulation is selected. So maybe vitamin K antagonist or direct acting like oral anticoagulant. So mainly when patient is having a atrial fibrillation to prevent the stroke or when they have a risk for LV thrombus. So maybe around 3 to 6 months or lifelong if they are having a AF. Okay. So not as a routine for all MI patient, that you need to remember. PPI may be like when patient is having dual antiplatelet for couple of week or maybe couple of days we can give. So nitrate as and when required. So sublingual GTN. So only for patient who are having a symptomatic chest pain. So there is no mortality benefit for not for all the patient. So again other diabetes medication. Okay. SGLT2 inhibitor, GLP-1 receptor antagonist. So like empagliflozin and liraglutide. So which helps in reducing cardiovascular mortality reduction in diabetic patient. Lifelong is the advice. So it is emerged as one of the standard therapy in the long term care for ACS patient. Okay. So other than this, is there any indication for device based long term strategy? So like implantable cardioverter defibrillator when they have EF of less than or equal to 35%. So after optimal therapy, like timing is somewhere more than or equal to 40 days post MI, we can consider in a individualized basis. So cardiac resynchronization therapy when their EF is less than 35%, LBBB is there and QRS is more than or equal to 150. In chronic phases, we can go for CRT. So stop smoking, BP control somewhere around 130 to 80, LDL target should be less than 55. Cardiac rehabilitation improve survival and quality of life. Weight, diet, exercise. So with a long-term goal, it should be advised. So long-term therapy after ACS is centered on lifelong antiplatelet therapy, statin, neurohormonal blockade, and aggressive risk factor modification with dual antiplatelet at least for 12 months following PCI. So that is a patient who had lots of complication with a severe anteroseptal MI. So we'll come back with many more cases with a